This is the summary of antibiotics. This is actually a 5-hour lecture content. I will try to finish in 30 minutes, okay? So, how to learn antibiotics? There are two major types, bactericidal and bacteriostatic. Study like this. Most of the bacteriostatic antibiotics are protein synthesis inhibitors. So we will study that in the second half. But here, all these antibiotics are bactericidal. Okay, antibiotics are antibacterial drugs. So folate synthesis inhibitors, nucleic acid synthesis inhibitors, there are two types, DNA and RNA synthesis inhibitors, cell wall and cell membrane. That's it. 5 different classes, okay, sections: cell wall synthesis, cell membrane synthesis, DNA, RNA, and folate synthesis. That's it. Okay, so let's start with the folate synthesis inhibitors. Only one major drug to study. This is a combination of two drugs, okay? Trimethoprim, sulfamethoxazole. Sulfamethoxazole is a sulfur drug, okay? So commonly asked questions, board question is, they ask mechanism of action, indication, adverse effects and contraindication in this section. So it kill bacteria by folate synthesis inhibition. So trimethoprim and sulfamethoxazole have two different mechanisms. So both are folate synthesis inhibition in two different steps. So both the enzymes are important for board exam. So sulfamethoxazole is a PABA analog, so they inhibit dihydropteroid synthase enzyme, but trimethoprim inhibit dihydrofolate reductase enzyme. So remember those enzymes, okay? Then these are pharmacokinetics related to the indication. That means these drugs are eliminated through urine. About more than 70% of trimethoprim directly eliminated in the urine. That is the reason it is very effective to treat urinary tract infection. Keep in mind, this drug combination is major indication for urinary tract infections, okay? Then adverse effects, when you talk about, these are sulfur drugs, right? If there is a combination of sulfur drug, the major one, a common adverse effect is phototoxicity, then rashes and skin related. One life-threatening adverse effect is Stevens-Johnson syndrome, and also this deposit in the urine as crystals because it is insoluble chemicals. So therefore this can cause nephrotoxicity. Therefore you should never combine another nephrotoxic drug with a trimethoprim sulfamethoxazole. Example, vancomycin. Try to avoid combination because of this adverse effect. Then also this is contraindicated in pregnancy. The next one is DNA synthesis inhibitor. There are only two sections, okay? So these two major classes. First class name is not important, Nitroimidazole, but Metronidazole and Tinidazole, two drugs are important to remember. Tinidazole is a new drug with a longer half-life, but it is a little expensive, so still Metronidazole is the most commonly prescribed drug. So mechanism of action, you understand, DNA synthesis inhibitor, but you need to know little more details. This is associated with the indication. Reason, indication, metronidazole is prescribed for anaerobic coverage. There is a reason for that. This is connected with the mechanism of action. This metronidazole is a prodrug. This will easily enter into the cell, but only activated in the anaerobic bacteria. The anaerobic bacteria with a P4 enzyme, or just study ferredoxin, okay? So if ferredoxin is present in the anaerobic in the bacteria, that is in anaerobes, they have ferredoxin, iron containing. So this enzyme going to activate metronidazole, so that metronidazole is going to chop the DNA of the bacteria, okay? That is the mechanism of action. Then, so this can it can pass blood-brain barrier, but mainly indication, remember, it can cover anaerobic infection. Okay. Then metronidazole has a two more point to remember: drug interaction and adverse effects. Of course, you should advise the patient about metallic taste, dark colored urine, and it can have nausea, but you need to eat with the food, use with the food, so that take with the food so that it can avoid or reduce nausea. Okay. And also metallic taste. But major adverse effects for board exam is psychosis. It can pass blood-brain barrier and it can cause neurotoxicity in higher concentration. But this psychosis can associated with an adverse effect in the alcohol, if you combine with the alcohol-drug interaction. The major term is disulfiram-like reaction. Of course, it is a most commonly asked board questions. Okay, question. So remember, if you combine with alcohol, disulfiram-like reaction in metronidazole. Next class is fluoroquinolone. So fluoroquinolone, 3 drugs: ciprofloxacin, levofloxacin, and moxifloxacin. So these are fluorine contained. So you need to learn the mechanism of action. Mechanism of action, it is a DNA synthesis inhibitor. How specifically you should distinguish from metronidazole and these fluoroquinolones. So this drug actually inhibit the topoisomerase, like a gyrase, DNA gyrase, topoisomerase 2 and 4. Actually, in gram-negative topoisomerase 2 and gram-positive topoisomerase 4 inhibition, if you wanted to know that detail, but board generally asks just the general mechanism of action. Okay. So then you need to know these 3 drugs very clearly. Ciprofloxacin and levofloxacin commonly used for urinary tract infection. How I remember is ciprofloxacin excreted through urine and feces, but levofloxacin eliminated mainly by urine, but moxifloxacin feces. So levofloxacin and ciprofloxacin can be used for urinary tract infection also, but levo and moxi are considered as respiratory fluoroquinolone. For pneumonia, it can be very useful. Out of all these 3 drugs, moxifloxacin has more anaerobic coverage. Okay, but most commonly used, very strong drug is levofloxacin. So you most commonly use this one. Okay, so let's look at that. This has some major adverse effects and drug interaction, and also contraindication. 3 things are very important in this one. Prototypical drug is levofloxacin. So these drugs have drug interaction with the antacid. That means when you prescribe this drug, tell the patients to avoid antacid while they are taking this drug. Okay, because it for the calcium chelation interaction, so that it absorb only very less when you take the oral drug. Another important point to remember: levofloxacin, these are longer half-life drugs, so that once a daily prescription is one pill a day is possible with this drug. And also about the major adverse effect of fluoroquinolones, most commonly asked board questions, right? That is associated with the deposit, accumulation of these drugs in fibroblast cells. So fibroblasts will produce our tendon, right? Associated with the tendon. Therefore, it has tendinopathy and Achilles tendon rupture are more or major adverse effects, and also associated with the chondrotoxicity and aortic rupture or aneurysm. Then this drug has also QT prolongation adverse effect. Therefore, if a patient already has QT prolongation, you should not prescribe these drugs. Or if a patient taking another QT prolongation causing drug, you should avoid this drug. Remember, in the fungal infection, fungal drugs, we learned about the azole. You should not combine fluconazole, right? That drug with the levofloxacin. That means try to avoid combination. Reason both can cause QT prolongation. So those are the major adverse effects. But out of that, Achilles tendon rupture and aortic rupture are major point, because this is associated with the fibroblast. Fibroblast. That is, if you wanted to know details, I can make it other lecture like a long videos. But keep in mind, this fluoroquinolones, like it can inhibit the DNA of bacteria. Similarly, in some of the cells, like in fibroblast cells, fluoroquinolones can accumulate and break our DNA. Therefore, people, humans can get this adverse effects. Okay, keep in mind. And then contraindication. So that's also a board question, right? Commonly asked board question. These drugs are contraindicated in pregnancy and children and patients under 18. How I remember is, this has a similar contraindication like in tetracyclines, example doxycycline, right? Of course, short time we prescribe, but still the contraindication is still FDA keeping that contraindication. So these drugs, fluoroquinolones, have contraindication in pregnancy, children, and patient under 18, but tetracyclines have pregnancy contraindication, children under 8. That's a contraindication. That's a difference when you study, distinguish those though. Okay. So remember, this sulfamethoxazole also was contraindicated in pregnancy. Okay. So the next one is RNA synthesis inhibitors. So there are these are two different class drugs. I don't want you to remember class name or anything, but study rifampin. Rifampin, remember, these are ripe therapy. These are drugs which can kill mycobacteria. So one example is tuberculosis drug, right? Rifampin, isoniazid, all those. I will make another video for tuberculosis drugs, okay? Next one maybe. Then Fidaxomycin, that is actually, okay, let's look at rifampin. Both these drugs, rifampin and Fidaxomycin, these are entirely different drugs, but they can inhibit RNA polymerase function. Therefore, just study RNA synthesis inhibitors. Rifampin for tuberculosis or mycobacterium, that is the indication, but I want you to study indication of these two drugs. Fidaxomycin. Fidaxomycin indication is, remember, in C. diff diarrhea, C. diff, Clostridioides difficile can cause, what is the diarrheal condition called? Pseudomembranous colitis, right? So that can be treated with this drug, oral Fidaxomycin. So we will look at that one more time later. But that's all in this section. Then let's look at cell wall synthesis inhibitor. Okay. So cell wall synthesis inhibitor, we need to learn of glycopeptides and beta-lactam. These are two divisions. Okay. So in this division, first, glycoproteins cover MRSA, that is methicillin-resistant Staph aureus, and vancomycin-resistant Staph aureus. There is other drugs are there. Okay, let's talk about that. These two drugs can cover MRSA, methicillin-resistant Staph aureus, but most of the beta-lactam cover only MSSA, methicillin-sensitive Staph aureus. Only one exception is ceftaroline. I will talk about that later. But keep in mind, what do you want? You must learn certain things about like glycopeptide. There is mechanism of action. There is difference. These are cell wall synthesis inhibitor, but they are not binding on penicillin binding protein. This is an entirely different structural difference. I want you to distinguish a DLA meioty of the bacterial cell wall, and especially they are going to board like to ask about the mutation, how resistant formation happening in the vancomycin drug, so in the bacteria. So that is one of the questions commonly asked, DLA changes, right? So refer that in this section. But keep in mind, vancomycin indication, I want you to study two major things: oral vancomycin indication and IV vancomycin indication. IV vancomycin indication, MRSA. Okay, MRSA coverage. Of course, there are many indications, but at least remember this one. MRSA coverage. Okay, very good. Then oral vancomycin, we can use it for Clostridium difficile or C. diff diarrhea. Remember? Oral, these are very large molecule, cannot absorb from the intestine. Therefore, it can stay in the colon and kill bad bacteria. Therefore, oral vancomycin is not to treat MRSA, okay? Only IV. Oral vancomycin is for C. diff diarrhea. That's a distinguishing features you have to remember. Then other important points are IV vancomycin has some adverse effects. So a couple of things to remember. Commonly called vancomycin, new name is vancomycin flushing syndrome. It used to called red man syndrome. Okay, that is a adverse effect commonly found. We can avoid with drugs, but other irreversible adverse effects are there. That's the reason you need to remember vancomycin can cause ototoxicity and nephrotoxicity. That is the reason, remember, the trimethoprim sulfamethoxazole can cause nephrotoxicity. So you should not combine that drug with the vancomycin. Vancomycin can deposit in both cochlea and also in the nephrons, okay, because these drugs are eliminated through urine. So therefore, these drugs also cannot combine with the aminoglycoside. That's another class of drug. We will talk about it. So let's talk about the resistance. You can study that. Then the new drug telavancin. This can cover MRSA, and also if there is a vancomycin resistant staph aureus, that can be covered. Okay. Then another new drug, tixobactin. Tixobactin is, I didn't include here. This is that can cover like almost every resistant strains of this bacteria. So VRE, MRSA, all those can be covered by tixobactin. Okay, so then let's look at beta-lactam. Those are a big classes of bacteria, right? Beta-lactams, cell wall synthesis inhibition, but binding on penicillin binding protein. Remember, and there's mutation or resistance also. Okay, I wanted to remember 4 classes. Monobactam, at least study one drug, Aztreonam. That's a commonly asked question, okay? Just one drug. These 2 drugs, Carbapenems, Imipenem-cilastatin and Meropenem. So Carbapenems and Monobactam is like a vancomycin. They are mainly used in the hospital setting, okay? The other outpatient drugs are in the other list we are going to discuss. Okay, let's look at it. Monobactam, one drug, like how I remember is Aztreonam. That means these cover gram-negative aerobic coverage is there. Okay, so remember these are covering gram-negative aerobic bacteria, and these are very strong bacteria. Sorry, strong drugs. Therefore, very used in hospital setting, not like a commonly used prescribed drug. Okay, so no cross reactivity with a beta-lactam. That is another important point to remember. If a patient has any patient has a beta-lactam allergy, you can use this drug. That's why it's kind of life-saving drug. Okay, anaerobic infection, and also another important point, this can pass blood-brain barrier. So that therefore Neisseria meningitis can be treated with Aztreonam. Okay, mechanism of action similar to the cell wall synthesis, similar to other beta-lactam. So next one, Carbapenems. I wanted to remember 2 drugs, Meropenem and Imipenem-cilastatin. Okay, Meropenem has less adverse effect. That is, seizure is the one of the common adverse effect of Imipenem, but Meropenem has less seizure. But just study one drug first so that it will be easy for you. Imipenem-cilastatin, what is the specificity of this drug? This is like it can treat polymicrobial, broad spectrum bacteria drug, antibacterial drug. This can treat polybacterial infections, and also polymicrobial infection, and also for it can pass blood-brain barrier. Therefore, it can cover gram-positive, gram-negative, aerobes, anaerobes, all the bacterial covering is a broad spectrum. So this is actually a last resort antibiotic. Keep in mind, Aztreonam has only aerobic coverage, right? Earlier we learned metronidazole has anaerobic coverage because it is prodrug, activate only its anaerobes. Aztreonam, aerobic coverage. Imipenem has both aerobic, anaerobic, gram-positive, gram-negative, all those. So imipenem easily eliminated from the urine, and also it can deposit in the nephron and cause nephrotoxicity. This can be prevented by adding another compound called cilastatin. Keep in mind why I put a different color. Cilastatin cannot kill bacteria. It is not an antibacterial antibiotic. No, independently it cannot use. But if you combine with imipenem, cilastatin has an entirely different function. What do? They actually function in our nephron. In the nephron, it can prevent the destruction of imipenem. Okay, so quick elimination of imipenem can be prevented by the use of cilastatin. So commonly asked board question, because imipenem combined with cilastatin, similarly remember Amoxicillin-Clavulanate, piperacillin, tazobactam. Last day we discussed another in antiviral drug. Remember cobicistat? That is actually a pharmacokinetic booster for CYP interaction, right? Inhibitor of CYP3A4. Similarly, those terms are very important. So remember, those are commonly asked questions. So if we talk about okay, I think we are almost done. Imipenem independently and combination with cilastatin can cause seizure. But keep in mind, never confuse. Cilastatin has nothing to do with that seizure. Imipenem is the drug causing seizure. Cilastatin is just saving that elimination of the drug, fast elimination of the imipenem through the urine, and also it also saved from the nephrotoxicity. Okay, so I hope you understood that very well. Then let's look at the penicillins. Okay, I wanted to study us together in one group, otherwise it is so hard for students to remember. How I teach students is penicillin G, A, B, C, D, F, G, then V, penicillin V. These are the first early penicillins. Penicillin G, not oral because it won't absorb well. Therefore, penicillin G, remember about injection, IM, right? Penicillin G, IV. So this is just study one indication. All these have common adverse effect. I'm going to teach you. But penicillin G, what do you have to remember? One indication that is actually syphilis. Okay, that is commonly asked about question, and question to remember. Then penicillin B, just remember at least one, strep pharyngitis. Ampicillin IV, actually IV drug, it can be used in all these drugs, can be used in pregnancy, like nursing, elderly patients. Okay, so let's look at amoxicillin. Amoxicillin, children we can give, adults also. Strep pharyngitis and acute otitis media, study at least one, otitis media, amoxicillin. But if it is a recurrent one, there should be a reason. If there is a beta-lactamase production in the bacteria, you should use Amoxicillin-Clavulanate. Now the question is, why do you use clavulanate? That's a commonly asked question. Okay, let's talk about Amoxicillin-Clavulanate. Study a couple of indications if possible. Amoxicillin-Clavulanate can be used for different, all these above mentioned, like pharyngitis, otitis, whatever. But for the board, I want you to remember, this is commonly used for animal bite, dog bite and all. Okay, just study like penicillin G for syphilis, Amoxicillin-Clavulanate, animal bite. Study that way because that's a unique one. Okay, so that's the reason. Okay, clavulanate actually a beta-lactamase inhibitor. It combined with amoxicillin. Okay, clavulanate will not alone, it cannot kill bacteria, but it can chop the beta-lactamase produced by the bacteria. Therefore, it can save amoxicillin, save the drug. Amoxicillin will be eliminated by beta-lactamase produced by certain bacteria, so that we are adding clavulanate. Hope you understood that. Okay. Then piperacillin tazobactam. This is piperacillin. This is a very IV, like a very strong drug. Okay, hospital setting we can use it, broad spectrum. I put P because this has pseudomonas coverage. Piperacillin can also broken by beta-lactamase producing bacteria. Therefore, we are adding tazobactam, that is a beta-lactamase inhibitor. These two different beta-lactamase inhibitors, but combination drugs. Keep in mind, okay? So combination, they're going to use it. Okay, so piperacillin is a IV, not oral. Amoxicillin-Clavulanate is oral. Okay, so now look at penicillin's adverse effects. Okay, before that I wanted to mention two more penicillins, nafcillin, oxacillin. Why this is important is, normally all the other penicillins excreted through the urine, okay, by nephron, but nafcillin and oxacillin excreted by to feces. That is an example. For instance, if a patient has renal dysfunction, you can use this drug, right? Because this is metabolized by the liver. That's an important point. So how this is for nafcillin and oxacillin, very effective for methicillin sensitive staph aureus, MSSA. So therefore, like if you have a pneumonic, nafcillin gets up in the morning and kill MSSA. So look at the shorts, mnemonic shorts, so that you will understand that. Okay, anyway, hope you understood all this penicillin. At least study the indication part so that it will be useful, and also this why is it combined with these compounds. Okay, mainly penicillin adverse effect, commonly asked board question. You need to learn two adverse effect, one most common adverse effect and a most serious adverse effect. Most common adverse effect is a rash, especially in children. It is called maculopapular rash. But maculopapular rash is IgG mediated delayed reaction. But IgE mediated very fast adverse effects, like a fast acting or a quick response is anaphylactic shock. That is actually life-threatening, right? Penicillin allergy, very severe one is anaphylactic shock, immediate but very serious. Okay, it's actually rare, but still board like to ask that question. Keep in mind all these penicillins, and this cephalosporins also has that general most severe indication, anaphylactic shock. Okay, so let's look at cephalosporins, cephalexin and cefazolin. Okay, what do you have to remember? First generation cephalosporin, two drugs, both are equally important. Cephalexin is an oral drug for aerobic coverage. This drug is effective, and gram-positive coverage like penicillin VK, right? But cefazolin is why is it very important? This is an IV drug which is very good for surgical prophylaxis. Therefore, if you make an incision in the body, it's easily from the skin, bacteria can get into our body, right? Therefore, just before surgery, patients receive this as IV. Cefazolin is a drug, IV prophylaxis. But keep in mind, if a patient is in that hospital suspected MRSA, you can give IV vancomycin during surgery. But still, commonly used one is, if there is no suspected MRSA, cefazolin is the surgical prophylaxis drug. That indication is super important. Then another one, ceftriaxone. Okay, so I didn't put second generation drugs here because I don't want you to confuse. Study that for board practice. But remember, those drugs, one of them can pass blood-brain barrier, and it can cover anaerobic coverage. Okay, study those. There is mnemonic there. But third generation, three drugs I want you to remember. Ceftriaxone, that is a broad spectrum drug. It is in the hospital setting, patients will get. This can cover both gram-positive and gram-negative coverage. Then anaerobic coverage and aerobic coverage is very strong. So another point, ceftriaxone You should never combine it with IV calcium. That is an important point. If it is given in elderly or infants or newborn, they can lose kidney and lungs because of the chelation and precipitation with the calcium. That's another point I would like you to remember. And cefdinir, it is very like a unique one because that is actually resistant, like a ceftriaxone. It is beta-lactamase resistant drug, especially the cefdinir. This has less drug interaction because it has a unique structure. Therefore, it is well tolerated drug. Oral drug is available, and a suspension with a sweetness or like a little bit sugary taste. Therefore, children like to use that cefdinir. Okay. Another thing, highly resistant to beta-lactamase, low allergic or toxicity compared to all the other cephalosporin. Then one more point, ceftazidime. So dime, this is for pseudomonas coverage. This is also third generation. Then the fourth generation, one drug like a dime and pime for pseudomonas. So cefepime is a fourth generation, pi 4, something like that you can remember. Cefepime is a fourth generation drug with a pseudomonas coverage. Study the rest of the points. Then ceftaroline will cover, that's a fifth generation cephalosporin, which can cover MRSA, methicillin resistant Staph aureus. Okay, if they can ask you if you want it, but I don't know. But out of all these cell wall synthesis inhibitors and all the penicillins and beta-lactams, only one drug which can cover MRSA, that is ceftaroline. Sorry, not cell wall synthesis. Out of cell wall synthesis inhibitors, you have vancomycin and telavancin can cover MRSA. But out of all the beta-lactam, only one, that is ceftaroline, can cover MRSA. But commonly used MRSA coverage drug is vancomycin. Okay, and linezolid, another drug we will learn in the next section. Okay, the last one, cell membrane synthesis inhibitor, that will be daptomycin. So all these are in this page. All these are one more page we have. This page we are talking about bactericidal antibiotics. So this one, daptomycin. This is very effective drug. This is actually a very strong drug, daptomycin. This can actually kill MRSA. It can cover MRSA, VRSA and VRE. Methicillin resistant Staph aureus, vancomycin resistant Staph aureus, vancomycin resistant enterococci. All those will be covered. And this is two more things I would like you to remember for the board exam. Mechanism of action is cell wall synthesis inhibitor. It has a drug interaction with a statin, because if you give this drug with a patient who are taking statin, it can increase rhabdomyolysis or muscle toxicity. Okay, so that's a drug interaction question. And you should never give this drug to pneumonia patient, because this drug can be inactivated by pulmonary surfactant. This is a board question, remember that. Daptomycin can be inactivated by pulmonary surfactant, therefore it should not be given to pneumonia patients. Okay, so that's an important point to remember for the next year, second year, and also for the board exam. Okay, so okay, so let's look at we have covered this section. Let's look at the bacteriostatic antibiotics. It's going to be easy, very short section. Okay, so in this section we will learn how protein synthesis inhibition, right? So how do they inhibit protein? So targeting 30S or 50S ribosome. So this is, I want you to remember that mnemonic. Smart students buy at 30 and sell at 50. So AT, aminoglycosides and tetracyclines are the antibiotics. Antibiotics in these two classes inhibit bacterial 30S ribosomes and thus inhibit protein synthesis. Remember this way, all the other drugs will inhibit bacterial bind and inhibit bacterial 50S ribosome, thus protein synthesis inhibition. That's how I remember. That's easiest way. AT for 30S. Aminoglycosides and doxycycline. Let's look at aminoglycosides, okay? So keep in mind, you need to it's different than other protein synthesis inhibitors. This is a very strong drug because of the molecular formula, right? These drugs can function as bactericidal agent, especially tobramycin. Very strong drug. Out of this, I want you to study amikacin and tobramycin for board exam. Very important because it is very effective for hospital setting. Amikacin, both amikacin and tobramycin are commonly used in the hospital setting. Okay, so how I remember is NATs: gentamicin, N, neomycin, amikacin, tobramycin, and streptomycin. Okay, so what do you have to remember? Amikacin has G negative bacterial coverage is there, and this can cover aerobic bacteria. Remember earlier we learned about in the cell wall synthesis inhibitors, Aztreonam, same, right? Gram negative coverage and aerobic coverage, similar coverage is there, but what is difference? So amikacin has pseudomembranous coverage, okay? Distinguish somehow. Then tobramycin, it is very effective in hospital setting. This can also used for like a pseudomembranous coverage, and also superficial and a deep tissue infection. It is commonly used drug, okay? And IV topical, like all these are available. It is not available in oral because P glycoprotein can do efflux pump, and thus it can be eliminated. Therefore, it is not given as oral. Keep in mind, okay? So the next one, doxycycline. So doxycycline, tetracycline generally, right? That is a most commonly asked board question because it has a lot of indications. So remember this protein synthesis inhibition binding on 30S ribosome, but the drugs doxycycline, tetracycline, minocycline, tigecycline, all these are there, like a lot of lists there, but doxycycline as a typical drug, study that way. Okay, so what do you have to remember? Indication. So there is a mnemonic in this section. You can look at it, refer that. Clara the stupid cat, Lyme disease, you can use it like all those chlamydia, Lyme disease, anthrax, rickettsia, all those lists. I want you to remember that. Doxycycline has drug interaction similar to our fluoroquinolone or levofloxacin, right? You should not give this with the combined with the oral doxycycline and calcium carbonate, antacid. This can cause chelation. That's the reason. And also this has adverse effects and a drug interaction. Those are very commonly asked board question. Adverse effects, multiple adverse effects. Always advise the patients not to expose to sunlight. Remember, it can deposit in the keratinocytes, so that when it is UV light fall on the skin, it can activate, and it can develop change into active compounds, and it can cause phototoxicity. Remember that? So therefore you should avoid exposure to sun, phototoxicity. Then gastric discomfort, especially in the elderly patients, chelation with calcium. What is the contraindication? Pregnancy contraindication, infants and children. What is the major reason? I want you to remember that. Doxycycline has a tendency to accumulate in the bones and replace calcium. But if the tissues are not remodeling, example, teeth, it's going to be permanent. Teeth, doxycycline has only mild, but specifically tetracycline, major drug, has that old drug. That is a typical one. Just remember that way. So it can irreversibly binding on the teeth if you use high dose for long term. But for the bones, of course, bones accumulation is also there, but it is because it is always replenished like a remodeled tissue, therefore it's going to be replaced. But keep in mind, in the pregnancy, fetal and young children's and infants, this can bind and cause developmental issue. That is the reason it should be, it's still contraindicated. But of course, if a child has a Lyme disease, there is no other drug. You should give this drug for short course, but otherwise the contraindication is still there. Okay, keep in mind that difference. Then macrolide. Nowadays, it was commonly used drug, still using, but macrolide has a lot of resistance now. Okay, but commonly asked questions. Azithromycin is the most commonly because it has a longer half-life, very long half-life. Once a daily dosing is there, compared to doxycycline, like twice daily. Then azithromycin, what is the major things to remember? Of course, protein synthesis inhibitors, remember, these are 50S ribosome. This section, all these drugs are 50S ribosome inhibition, okay, protein synthesis inhibition. So azithromycin, indication of these drugs are, they can cover, of course, gram positive, gram negative coverage is there, but these drugs can cover atypical bacteria, mycoplasma, okay. So atypical coverage is very like a higher in these drugs. That's a one point to remember. Then if you wanted to compare these drugs, other point, gram positive coverage is more in clarithromycin than erythromycin and azithromycin, but gram negative coverage is more in azithromycin. Okay, if you can, if you wanted to distinguish. But clarithromycin has a lot of drug interaction. I wanted to remember. Usually board like to ask CYP interaction, CYP3A4 interaction. Therefore, avoid with a simvastatin, or you have to do really continuous dose adjustment. Okay, QT prolongation, all those points. Remember, refer that. Azithromycin, longer half-life, once a day dosing, atypical coverage, all those, right? Well tolerated drug, right? Okay, so the next section, linezolid. So linezolid is, it's like a last resort drug. It's in a hospital setting. If vancomycin didn't work, this is the drug to go for. MRSA coverage is there, VRSA coverage is also there. That is vancomycin resistant staph aureus also, methicillin resistant staph aureus, and also both can be covered. So this is a super important drug. So I wanted to remember equally important like vancomycin. So this drug has an adverse effect, that is bone marrow suppression. And also for board like to ask, you should never combine this drug with an antidepressant, because serotonin syndrome can be possible, and GI side effects are also there, also common because of the its interaction with the serotonin. Okay, so sorry, it's don't worry about it. We can just study serotonin. I will explain that in another video. But serotonin syndrome, and therefore should not linezolid, never combine with the antidepressant. Remember, daptomycin I was talking about, that is a super drug. It is covering MRSA and VRSA and all, right? Daptomycin, you should not combine with the statin. Remember, drug interaction we were talking. Also should never give to patients with pneumonia, because it can digested by surfactant. Those are important. So similarly, linezolid cannot combine with the antidepressant. That is a board question, commonly asked one. The last drug, that is a most commonly asked board question, so therefore I saved it for last. Clindamycin. Okay, so before that, remember, you heard about a drug called chloramphenicol. It is not used in United States, but still board like to ask questions like that. Phenol containing, it's very strong drug, but it can cause gray baby syndrome. That means if a pregnant woman take it, the patient, like a young one, we killed a lot of fetus with this drug. So therefore we are not using chloramphenicol. But anywhere if you read about gray baby syndrome, chloramphenicol, that is also a protein synthesis inhibitor. But last drug, clindamycin, lincosamide class, okay? But don't worry about the class. Clindamycin, this is inhibited, it is a protein synthesis inhibitor, that is 50S ribosome inhibition. And what else you have to remember? This has a very good coverage of, it can penetrate bone, and also this drug can cover gram-positive and gram-negative bacteria. So that is the reason it is usually in the dentist, especially in the oral infection. This is very effective drug. And when you study, you can remember cloud above, metro below. Metronidazole usually below the diaphragm, clindamycin above the diaphragm. But of course, you can there is changes, but just study somehow. Both these drugs can cover anaerobic coverage, but clindamycin has both aerobic and anaerobic coverage is there. Okay, and I was looking at about the adverse effect. That is a major thing board like to ask, other than the mechanism of action. Clindamycin actually, let me look at where it is. Diary. Okay, clindamycin. Did I miss anything? Gram-positive aerobic coverage. This has cover. Okay, this has a MRSA coverage. I forgot to write it down here. Clindamycin can cover MRSA. Okay, remember. Then, because that is the one difference between doxycycline, right? Doxycycline also can cover atypical coverages lightly there, like azithromycin. But doxycycline can penetrate bone like clindamycin. But how is it differs from doxycycline? MRSA coverage is there for clindamycin compared to the other drugs. Okay, so then clindamycin induced dosing is about 4 times a day, because it has very short half-life. That's another problem, right, about this drug. But well tolerated, especially dentists prescribe this a lot. And if there is any penicillin allergy or beta-lactam allergy in the patient, these are the 3 drugs we usually you are going to choose for outpatient: doxycycline or azithromycin or clindamycin. That is the reason these 3 drugs are commonly asked board question. What is the other important point board like to ask about clindamycin? The adverse effect. Adverse effect, this can lead to the overgrowth of Clostridioides difficile in our colon. Remember, Clostridioides difficile is the old name is Clostridium difficile, right? Okay, C. diff. C. diff causes C. diff diarrhea. So this clindamycin can kill a lot of good bacteria from our body. Therefore, some very minute number of Clostridioides difficile in our human body start multiplying and damaging our intestine. The condition is called pseudomembranous colitis. That is a most commonly asked board question. Another most commonly asked board question is, how do you prevent this? How do you treat? If it is very severe, you should advise the patient to go to the emergency room. That is very important, because it can lead to bleeding and all the complication. So diarrhea will be severe. Otherwise, you can treat with a oral vancomycin or oral fidaxomycin. Out of this, old days we used to treat oral metronidazole, but now CDC and FDA recommended to stick with this, because those can cause a lot of resistance and recurrence. Patients can get C. diff diarrhea again in their life. To prevent that, the first choice for clindamycin-induced C. diff diarrhea or pseudomembranous colitis, first choice is oral fidaxomycin. Okay, oral fidaxomycin. Then give, oral fidaxomycin. If you don't have oral fidaxomycin, give oral vancomycin. Okay, so I was planning to do that in 30 minutes, but it went to 50 minutes. I'm sorry about that. But I think I covered major points. Hope this is helpful. Okay, all the best. I'll make like individual videos in future. The next one will be cancer drugs or anti-mycobacterial or anti-tuberculosis drug. Okay, bye.